All right, welcome to the therapy lecture. We will get started right into it and talk about some ways that um, pre-psychologists, pre-psychiatrists tried to treat mental disorders and unusual behavior. Now, way back, hundreds of years ago, there's no psychology, there's no psychiatry, you know, there's very little knowledge about what causes people to have mental disorders and what causes people to behave strangely. And so a lot of it was old superstitions, and a lot of it had to do with religion and things like being possessed and lots of strange ideas about how to treat people like that. For example, on the left, uh, see, the idea was that the person was acting strange. They needed to be calmed down a little bit, and maybe one way was to suspend them in these contraptions, have them suspended for a while just to get them to calm down and stop, behaving strangely. I don't know if this had something to do with thoughts about the alignment of the spine or something. I don't know if that was part of it, but in a similar kind of vein, in the middle, you can see the same kind of principle behind this. Sort of looks like a electric chair almost, but you can see the legs and the arms are strapped down, body strapped down. The head is sort of prevented from taking in stimuli, by you can't really see or really hear very well. And the thought was the person who is acting strangely is overstimulated. So we need to remove them from being overstimulated. So to prevent, you know, them from walking around or interacting with others or seeing things or hearing other things. So just put them in a quiet room and, strap them down. And after however many hours or days, then the thinking was that they would be calmed down, but their so-called episode would have passed. And then even more sort of barbaric, if that wasn't already, you've got on the far right, and this goes back even further than a few hundred years, maybe even into a couple thousand years, um, drilling holes in the skull. And you're saying, well, how is that going to cure the person? And unfortunately, it had the unfortunate side effect of killing the patient. But there's no more strange behavior. But what the thinking is behind this is that the person who's acting strangely or thinking strangely is being possessed by a devil. So what they need to do is to get the devil out. And a way to do that is to just basically drill a hole in the head and then provide an exit door for the devil, that evil spirit to get out. And the thinking was then the devil would get out and then the person would be fine. Not really successful, right? Treatments for past illnesses. And even really a kind of a revolution took place around the late 1800s, maybe like 1905, 1900, somewhere around there, with a woman named Dorothy Dix, Dix. She exposed the cruelty of the state hospital system to the world. Really, people didn't really think about it very much and didn't know how cruelly psychiatric patients were being treated. What people were doing was they were just basically warehouses for crazy people. There's no attempt to help them, to treat them with dignity, to get them any kind of therapy. They were basically just thrown in these cold, dark cells with like hay on the floor and literally sometimes chained to the floor, and they were forgotten. It was just this horrible, horrible treatment, and she exposed that to the rest of the world and got a huge reform in the way that people psychiatric patients were treated. Now let's move a little further into a different discussion, and is the different types of therapists. And you don't need to know this really for the exam, but just sort of for your own knowledge. You can see there's lots of different types of therapists. A psychologist has a PsyD or EDD, or most commonly it's a PhD. Psychiatrist has a medical degree and is the only one that can prescribe meds. So they do their medical rotation, and then they do their specialty, their residency, so to speak, in psychiatry. Then you have the psychoanalyst, which is a specific type of therapist. Basically, they're a Freudian therapist. Anytime you hear someone talk about analyst or analysis, or are you analyzing me, that only refers to Freudian analysis. No other, that term doesn't really refer to any other type of therapy. There's not a lot of Freudian therapists out there. Contrary to the stereotype, there's not very many. It used to be really huge, prior to, like, say, 1960. But ever since then, it's been on the wane, and it's fairly unusual today to find some people still doing classic Freudian analysis. And you can see social workers and marriage and family therapists and psychiatric nurses. And here is, now these are old data, right? 2002. But the approaches, and I'd say definitely the psychodynamic, right? Psychodynamic also refers to Freudian analysis. That yellow portion can be a lot smaller today. Behavioral portion, that 3%, is going to be a lot bigger today. And eclectic is probably going to be still the biggest. Eclectic just means that it's a hybrid, like a mishmash. Like probably the most common eclectic, sort of blend is cognitive behavioral approach. Because that's what most of the people who come to see you, they'll have either issues with the way that they think about the world, right? So that would be the cognitive approach, or issues with some of their behavior. For example, some of the things that they've learned in their past learning history, right? They've learned to pair a fear response with flying. So that would be a phobia, which is easily treated with the behavioral approaches. Okay, gives you just an idea of all the different types of arenas and areas and specialties in therapy in psychology. Okay, let's talk about the approaches to treatment. And of course, the first one we'll talk about is the psychoanalysis. Now, Freud thought that with the way to treat, that basically disorders comes from stuff that's going on in your unconscious. Repressed urges, repressed anger, wishes, sexual thoughts, and so on. So he says that in order to understand what's bringing you your problems, you need to understand what's going on in the unconscious. So we need to do things like dream analysis, things like free association, and so on. And the idea is that if you can understand what's going on in the unconscious and get some of that stuff out of your unconscious, let the person sort of express it somehow, then that will alleviate then the sort of the conscious behavioral and maybe emotional and cognitive problems the person's presenting with. So goals in the Freudian approach would be catharsis, which is a intense emotional release. That, according to Freud, is great because it helps promote the suggestion that helps the client be willing to be open to the therapist's suggestions. And that's actually something that a lot of therapists use today. We'll talk about other therapies a little later, but that's that turns out to be an effective tool. The more that you can raise the client's emotions, the more susceptible to suggestion and direction from the therapist. Another one, insight. Sort of the aha moment. Understanding, oh, okay, I see now what's causing me to do this is this, right? And that's, we really want the client to understand that, to get to that point. With some ways that analysis and Freudian therapists do that: free association, like I mentioned earlier, where I'll say a word, you say the first word that comes to your mind. The idea behind this is you can get past the person's defense mechanisms, and then there's no right or wrong answer, and then they'll say the stuff that usually pops up then is stuff that's in their unconscious, and it's the job of the therapist to try to understand any kind of patterns in the answers that they say, right, and then from that derive an understanding what's in the unconscious. Now, resistance is interesting. You wouldn't think that would be helpful, but actually that is helpful. What this means is, let's say you're going around, we're making good progress, and I say, let's talk about I don't know. Let's talk about the summer camp when you were 4 years old, or whatever, something like that, or your family vacation when you're 4 at the lake. I don't want to talk about that. Right? That's what the client says. Now so they're showing resistance, and so you're saying, well, why would we encourage resistance? And it's not necessarily that we encourage it, but when we come upon it, then the therapist thinks, oh, there's something here that should be explored, right? There's something very clinically meaningful that we need to explore, and it could be the root of many of their issues. And the reason why they want to talk about it is because it's uncomfortable to them, which is precisely why we should talk about it, right? And another thing that we need to utilize, that can be utilized, but it's got to be careful with this, is transference. Transference is where the client starts talking to the therapist the way they would talk to another important authority figure in their life, like parents or whoever it is. And that happens, quite frequently, and it's usually easy to spot. But it's interesting that a therapist needs to be, constantly on the watch for this kind of reaction or treatment from the client. And if they catch it, they can either elect to pursue it a little bit, and use it as a tool, or basically to kind of deflect it and maybe steer away from the conversation, away from that kind of interaction, or just flat out tell the client, hey, I think you're talking to me like how you would talk to your dad or your mom. But you can use it clinically and a little bit but again, with great restraint. You don't want to promote any kind of maladjusted dynamic between the client and their significant, their an authority figure by saying the wrong things. Okay. Now, with the advent of HMOs and some and other concerns, analysis has had to change quite a bit. Classic analysis takes a long time, costs a lot of money, and sometimes you're never done. So brief psychoanalysis has come around where the HMOs are saying, no, we're not going to pay for this patient to be in therapy for 20 years or 30 years. That's ridiculous. Let's try 2 months. So you don't have the luxury of enhancing, we don't want to do resistance. We don't want to, resistance is not encouraged, right? Because that slows down. Anything that slows therapy down, no. And also, in brief analysis, right? Classical analysis, all you're talking about usually is your first 5 years of your life, right? Because he says that cerebral action is psychodynamically first, and anything happens after that is your personality is already set, and so on. But in brief psychoanalysis, okay, so again, to recap so far, don't do anything that slows down therapy. We only have 8 weeks, according to the HMOs, or somewhere very short amount of time. And we're only going to talk about stuff that's like today, in the here and now. We're not going to talk about your past, your first 5 years of your life or any of that stuff. We're going to talk about what's bringing you to therapy right now. So we'll use psychoanalytic concepts and to try to understand their current behavior. And it'll be a little bit more directive because we want to try to, meaning that the therapist is telling the patient, here's what's going on with you, here's what you need to change. Whereas in the past, and with a lot of therapy, in general, you want to kind of let the client, sort of steer the car, and be in charge of like what they want to talk about and so on. Not be directive. Now, so the criticisms of classic psychoanalysis I've kind of already touched on. One is that it takes too long. Another one is that it's not falsifiable, that you just say, here's what your problem is, and the person says, no, I don't agree, and then the therapist says, well, you're just in denial, right? And so it really is when I say this. This is not really falsifiable, and that's not good. You can't have it be the case where the therapist is infallible, right? There has to be some fallibility, some possibility that they may not be quite accurate. And then the last one is leveled at Freudian analysis, but also at all of therapy in general, and that is that it doesn't work. And that's not true. When you look at a sort of a comparison of both Freudian analysis and, I don't know if I have this on the next one. Yeah, I may have this on another slide later. But when you look at sort of outcomes of going to therapy in general, just any kind of therapy, versus staying home and hoping it gets better, the former, right, therapy, the average patient does much better than someone who even does really well, but they're by themselves. They're not in any kind of therapy. So basically, the bottom line is that therapy does work, and it is effective, and it's worthwhile. So that's not a valid criticism. But again, just to recap the criticisms, that it takes a long time, and costs a lot of money, not falsifiable, and it doesn't work. Those three. Now, current therapy, and this is from The Sopranos. You probably recognize that. Guy on the right is Tony Soprano, the mob boss, and it's his therapist. But this is actually not unusual in terms of what a typical therapy session is, where you see the people just sort of sitting there, they're just having a conversation. I will say that it is, I don't know what her orientation is. I think it's just, cognitive behavioral, but she seems to have that classic Freudian couch, right? The Freudian couch idea, the whole thing where they lay down and the therapist sits like behind their head and says, tell me more. That's classic analysis. And the idea was that you don't want to have the therapist be in their person's line of sight. You don't want them occupying their thoughts. You want them to kind of be a disembodied voice, just sort of letting them focus on whatever. And you want to have them relax and not be stressed out. But most therapies today don't have you lay down. You'll sit like this. Behavior therapy. Now, in behavior therapy, you can sort of see, this might be good to jot down some of this for your own notes. Right, you can see the foundation of behavior therapy is based on classical and operant conditioning, and saying that the source of the problem is maladaptive learning, behavior problem patterns. Right, you've got this flawed learning history. And so the treatment technique is, there's different ways. Aversive conditioning, flooding, token economy, observational learning, systematic desensitization. We'll talk about a few of those. Goal is basically to unlearn these maladaptive behaviors and relearn more appropriate behaviors. Now, the first sort of sub area in here we're going to talk about is classical conditioning. And one of the more controversial is this concept of flooding. And this is one of my favorite Far Side cartoons ever. Uh, Professor Gallagher and his controversial technique of simultaneously confronting fear of heights, snakes, and the dark. This is poor guy hitting all three, right? Hanging out there on this little booth. Now, while it's pretty funny, but this actually is flooding at play, right? So here's what is, if you're saying what is flooding? Flooding is, let's say someone's got a fear, right? A phobia, like a fear of heights, okay? So there's different ways to treat it. Now, flooding basically is where you expose the person to the full amount of the feared stimulus all at once, right? So let's say if they're afraid of heights, we're going to take them up on the top floor of the Empire State Building, right? Or if they're afraid of flying, we're going to take them flying. Afraid of swimming or deep water in the pool, throw them in the deep water of the pool. Full amount of the feared stimulus. The idea is that while it's terrifying, I mean, in the first few minutes or however long, that eventually, with the therapist standing right there, therapists are there to help them calm down, they will calm down. They'll realize that it's not the end. I'm not dying. It's not the end of the world. There's nothing to be afraid of, and now they've basically kind of broken that association between the stimulus and fear. The fear is abating and maybe even disappearing. And so now what they've learned, and the therapist has to, and it's kind of tricky with this, you have to not only calm them down, but then have them go through some relaxation training, where you have them close their eyes and visualize more positive thoughts and have them do muscle tensing and relaxing to help them feel relaxed. And the idea is that they now are pairing a feeling of being relaxed and at peace with the feared stimulus. Okay. So it is controversial because some people might say it's unethical because you're really terrifying. The person's really scared to death in those first, few seconds or minutes when they're exposed to the full level. Right? For example, fear of spiders. We're going to have you hold a tarantula or maybe let one walk on your face. Just terrifying, right? Okay. Now here is the more common way to deal with a phobia. Remember I mentioned that phobias are the most treatable of pretty much almost any of the disorders. It's one of the most treatable. High success rates, 85, 90, 95%, way up there. Now, with systematic desensitization, what we're going to do is we're also going to break the fear response, like we did with flooding, but we're going to do it over time. So, and it's different with different people. This is just one depiction, but it could take, for some people, to go through these different types of exposures, might take, let's say, a couple weeks. But other people might take many, many, many months. It's different for different people. It just depends. So, they come up with a plan, the therapist and the client. Okay, you're afraid of spiders, and we're going to get you to not be afraid of spiders. So how are we going to do that? We're going to say that we're going to measure your heart rate, and once it gets down to 70, we're ready to move on to the next phase, right? And so the question then is, how long is it going to take for the person to get down to 70? Well, we're going to expose them, and what we're doing is we're exposing them to tiny little increasing increments of the final, approaches and approximations of the final feared stimulus. So the first one is a picture of a spider, right? And it's a little far away. And let's say for this particular woman, it takes 3 sessions before her heart rate drops down to 70. Then we're going to give her this, have her hold the picture of the spider, which is really scary. Heart rate jumps up, and now let's say it takes another 4 or 5 sessions for her heart rate to drop down to 70. And you can see how this can take a while, right? But it's a slow process. Then you got a fake spider, and the therapist is holding it. and the woman is holding the fake spider. Now you've got a real spider. Therapist holds a real spider. She's holding, and you can break this up into even smaller increments, right? Like you could have on the top right, the therapist holds the fake the fake spider in its hand, his or her hand, 20 feet away from her, and then we'll wait and see how, and then maybe move to 10 feet away from her, and now right in front of her face, as you can see. So you can break these up and make them even smaller, but very successful in treating phobias, systematic desensitization. Third, on the top, aversive conditioning. Now, with aversive conditioning, you're trying to get them to unlearn the pairing. Usually it's pairing of pleasure with something that we don't want them to feel pleasure with, like, let's say, alcohol. So with aversive conditioning with alcohol, what you would do is you're trying to bring in this alcoholic, let's say, and you have them come in and you give them some alcohol, and they're thinking probably to themselves, "This is awesome therapy. I love this." But unbeknownst to them, you've added a chemical that makes them get violently ill when they drink it. So they drink their shot, or a glass of wine, whatever it is, and they get really violently ill. The idea is that they're going to now pair the thought of alcohol, or really, hopefully, any alcohol, with feeling very terrible, right? That violently ill feeling, and no longer feeling a desire to go for alcohol. It's also been used with, for example, like rapists and pedophiles, where you show them different things on the screen, and every time they get aroused, let's say, to something that they shouldn't be, we don't want them to, they get a shock. It's a little bit more chancy in terms of how effective it is. Like, maybe it will work for maybe 25%, or maybe even 12% of people who do it. I mean, in terms of thoroughly working really well. So it's both controversial and sometimes it could be a long shot in terms of really breaking that association between the inappropriate stimulus and the feeling of pleasure. Okay, now operant conditioning, we're moving on to the different type of therapy where you want to direct and change behavior based on rewards and punishments. Like a token economy is a good example, where a token economy is where you reward certain behaviors, certain amounts of behaviors, like a fixed ratio schedule, fixed amount of work has to be done before they're rewarded. Like, if you ever had one of those cards, like from a sub shop or a Starbucks or something, where you buy X amount of something and then you get the next one free, right? So buy 6, footlongs, and you get the 7th free, or something like that. That's a token economy. You're rewarding particular behavior. Parents do this, for example, right? Like, if you make your bed and you keep your room clean, you clean your room every day, then on Saturday you're going to get rewarded with an allowance. Things like that. Now, social skills training is interesting in that some people, you may have noticed people like this in your life, seem to have kind of not really gotten all the sort of social skills that a lot of people have just in their normal growing up. So, for example, they may not know what are appropriate things to say, when, like, what are the cues that other people are giving, verbally and non-verbally, that they may not be interested anymore in talking to you, or they're trying that they need to leave, or the other person's trying to wrap up the conversation, right? And those are subtle things. And so what will happen in therapy is the therapist will model the appropriate behavior for the client, and then they'll have the client go out and do the behavior sort of homework, and then come back and tell the therapist at the next session how it went. And they'll keep revising it. Okay. Now with cognitive therapy, different types of cognitive therapy, but we're focusing on sort of relearning better ways or more adaptive ways of responding to the environment and interpreting the environment. So like with rational emotive therapy, this is from Albert Ellis. The goal here is to identify irrational thoughts. And emotive is what he's saying is we're going to increase the emotion in the client, like we were talking about earlier, right? Enhance emotion. So here's our buddy Ellis. You've got irrational beliefs and assumptions that are causing you to feel negatively and also to do maladaptive behaviors, which further feed into your irrational beliefs. So what Ellis says, for example, is let's say, the person says, "Oh, I got passed over for a promotion, and now I'm really bummed out." They come in and talk about it. Now, what Ellis says is let's not necessarily a straight line between that and that, right? Let's try to understand maybe what are your beliefs that are causing you to be miserable. Because some people get fired or passed over, let's say, and they feel relief, or there's a yes, or they break up with their significant other and they get to, a lot of people get depressed, but some people break up and they feel great. And then, oh, I'm glad to be done with that person, or it's great to be single again, or I didn't see it coming, but it's definitely for the best, right? So the question is, what is, if it was always the case that breaking up with someone always made you sad, that would be a straight line. But he's saying, no, there's something in the middle that's causing your consequence, right? The feeling, the reaction, and that is your beliefs. That is, how do you interpret or construe the initial event? So, for example, the activating event is you're passed over for a promotion. And that triggers beliefs like, irrational beliefs like, I have to be successful in everything I do. I was a failure, so I'm going to be a failure, and I'm a worthless human being, right? This sort of catastrophic cascade of irrational beliefs causes a person to be definitely going to feel depressed if you're having these horrible thoughts about yourself. What he's saying is he's going to go in there and confront the person with these thoughts that the person's expressing, these beliefs. Is this really rational? Is this logical to think this way? I mean, have you ever been fired or passed over? But in the past, yes, many, a couple times. And then what happened? Oh, then I got a greater job, or I realized that wasn't a job for me. You see, right? That the world doesn't end because you passed over for a promotion. And, and he's trying to get them to react in a more adaptive, healthy way instead of going to these irrational beliefs. We don't have to go through all these, but these are just some examples. Like number 7, you need to rely on someone stronger than you. Number 9, you should become really upset at other people's problems. That's obviously irrational. Number 4, it's catastrophic when things aren't the way that you would like them to be. Of course, that's irrational, right? But these are examples of things that he tries to tackle and identify with clients, walk them through the initial event, and then how they're feeling, and talk about the middle, how they perceive it. It has everything to do with affecting their current feeling. Now, Beck is known as sort of the father of modern sort of research on depression. Aaron Beck started his work in the 60s on this, and is a brilliant pioneer in the work on depression. And his therapy has a lot of similarities to Ellis's, right? Saying that you have illogical ideas, right here on the left, that lead us to feel awful, right? That little orange bubble in the middle. And then feeling awful triggers more negative thoughts, and that leads us to feel even more awful. We might call that depression, right? Negative affect could just mean, basically meaning feeling bad. And depression is sort of the clinical level in some cases, or just feeling even worse. But anyway, so his therapy, as you can see on the top right, is focusing on changing this kind of thinking, these illogical ideas. Beck says that people who are depressed have what he calls a negative triad. And that is a negative view of themselves, of the future, and of the world. Right? The self, future, and world. And so what he tries to do is go in there and understand what are those their views of themselves and the future and the world. Try to understand what are their illogical ideas pertaining to each, and then go in there and try to change each of those. And that will hopefully short circuit this process and alleviate their depression. So you can see, if we're going to compare these two, lots of similarities, like I said. Ellis says source of the problems is irrational beliefs. Treatment is to basically be very directive and confront the person and get rid of the irrational beliefs. Now, Beck says source of the problem is unrealistic perceptions or interpretation of the environment. Treatment is to basically teach them about the accuracy of these perceptions, correct these disordered thinking, this illogical thinking. Okay. Now, another approach, which is interesting, is the humanistic approach. Right. So we've been talking about we so far have talked about Freud's approach, behavioral approaches. Then we talked about the cognitive approaches, and now we're talking about humanistic. And Rogers and also Maslow, we really didn't talk too much about, but they were both considered humanist psychologists. But Carl Rogers, from going back to the 40s and 50s, was and into the 60s too, was a brilliant clinician and therapist. And his view was, in terms of therapy, he calls it client-centered therapy or person-centered therapy. And basically the reason why that is to let the client direct therapy, right? So it's sort of very non-directive on the part of the therapist. And so what he says is people come to therapy, and the reason they come to therapy is they have problems with whatever it could be, like depression or relationship issues or whatever it is, self-esteem problems. And what he says, though, is the reason why people have these issues is that they had issues in their first 5 years, so he's a lot like Freud in that respect, with their primary caregiver not giving them what he calls unconditional positive regard. And I don't know if I have another slide. No, I don't have another slide. Unconditional positive regard is this idea that your parents love you no matter what you do, right? They may not like what you did, like the behavior, but they tell you, with no uncertain terms, that they will always love you. So there's no, right? There's unconditional, it's not conditional, and positive regard. And so he says we need that as a basis for our healthy personality development. If you get the message from your parents that they love you only sometimes, like only when you get good grades, or only when you're acting like your older brother or sister or something like that, then he says that presents us with conditions of worth, that there are conditions under which we will be valued or loved. And if we if we don't meet those conditions, or when we're not in those conditions, we're not loved. That's the message the child gets. That leads the person, according to Rogers, to have all kinds of maladaptive issues like attachment problems and distorted way of looking at relationships. So what he says the job of a therapist is to identify, again, first this what happened in these formative years in the person's life, see how their what relationship is with their parents, and but also to communicate to the client that this therapy session is a place of sanctuary and non-judgment, that they are a worthwhile person, and that the therapist values them as a person, and that they have worth. Right? They're an important person. They should feel that way. The job of a therapist is to kind of repair the cracks on the foundation of the person's personality by communicating this sense of self-worth that they probably never had from their parents. Okay, that rounds out our whole discussion on therapy, the 4 different approaches. Hope you enjoyed it. And actually, this is our last lecture, so I hope you enjoyed this short summer class and got a lot out of it. And look forward to seeing you, hopefully, in future classes. I'm going to be on sabbatical this fall, but I will be back in the spring of 2017. So, again, thanks for taking the class, and I will see you, hopefully, some of you, early next year. All right. Bye.